Next speaker is Professor Zolf Mughal. Professor Zolf is a consultant pediatrician since 1988, and he is a consultant in pediatric bone disease at the Royal Manchester Children's Hospital. His lecture is about an approach to a child with a history of fracture.
صوتك يعني شو تغير يعني معروف
Good afternoon, everyone. Once again, I would like to thank Abid, Sophia, and Nancy for their very kind invitation and the wonderful hospitality. So this is really a continuation of the talk that I gave this morning, but this time I'm going to focus on a child who presented with fractures, and I'm sorry that we're going from exciting diabetes to bone disorders. So the learning aims are to provide some understanding of what osteoporosis is in children and adolescents, how do we go about assessing bone health, and what can we do for children who come in with fractures. And of course, it's not only adults who get fractures. So on the left panel here, we have a child who has had an injury on the soccer field, running and falling onto outstretched arm and sustained a classical fracture of the distal end of the radius and ulnar. Whereas in the middle panel, you have a child who has a chronic illness and has developed fractures of the vertebral bodies which have occurred insidiously. There hasn't been any loading whatsoever. Now, normally a child would only sustain vertebral fractures if he or she fell from a big height and landed on their bottom, or were involved in a road traffic accident. And the last panel here is a child with cerebral palsy, where there has been sort of incomplete loading or inadequate loading of the growing bones, and you have very slender bones which require very little force in causing that break, and such forces can arise during normal handling. So, how do we assess a child who presents with a fracture? Well, of course, you take a detailed medical history and you carry out an examination. And the key questions are, how did the fracture occur? Was it a low velocity fracture, or did it occur as part of a road traffic accident or on a soccer field? And backache, persistent backache, is an important symptom in a child which should not be ignored. And we do a quick musculoskeletal examination. I would all urge those of you who are interested in pediatric musculoskeletal examinations to go to the PGALS assessment. That's pediatric gait, arm, legs, and spine. This has been devised by Professor Helen Foster at the University of Newcastle. She's a rheumatologist, and this is a really quick 5-minute assessment where you can do a very thorough musculoskeletal examination of the child. Puberty has an important impact on development, so pubertal assessment is very important. Of course, it's important to exclude chronic illnesses like celiac disease and inflammatory bowel disease, and important to estimate that they have adequate intake of calcium, check their vitamin D status, and basic bone labs. And radiographs, and I'll mention a little bit about DEXA vertebral fracture assessment, and this morning I sort of gave a talk on the logical use of DEXA in a child. So let's start with some real cases. So the first case is Michael, who was referred at the age of 13 and a half years by his general practitioner because the parents were concerned that he might have brittle bones. At the age of 11 and 40 years, he fell on playing football and sustained left distal, radial, and ulnar fracture. When another 6 months later, he fell on an icy pavement and fractured his left distal tibia. And previously, he had fractured at the age of later 12 and a half years, fell whilst running and fractured his elbow. And at 13 and a quarter, he fell off a trampoline and sustained left distal fracture. So more than his fair share of fractures. He ate a balanced diet but was not keen on dairy products. He had normal bowels with no blood, slime, mucus. Was taking multivitamins for over the counter. He played football, soccer, cricket, rugby, and swam occasionally. When When you examined, he had a little bit of eczema. He had tendency to walk in his forefeet. So when you did the P-GALS examination, rather than having a normal gait where you land on your heel and then put you in a forefeet, he tended to walk on his forefeet, and we'll come back to why that is important. His height and weight were fine. There were no clinical features of osteogenesis imperfecta, Marfan syndrome, or Ehlers-Danlos syndrome. He was mildly hypermobile with Baton score of 6 out of 9. I'll come back to the Baton score. He had tight tender Achilles. An examination of spine and tendon reflexes, which you have to do if you are walking on tiptoes, was quite normal. His labs were essentially normal. Calcium phosphate, alkaline phosphatase was normal, parathyroid hormone was normal, and because he was taking vitamin D supplements over the counter, his 25-OHD was also satisfactory. Nothing wrong with his hemoglobin, full blood count, platelets. Screening for celiac disease was again nothing to worry about, and same for orozomucoid, which is an acute phase marker for inflammatory bowel disease. So the question is, does Michael suffer from osteoporosis? Well, as I just mentioned this morning, osteoporosis in children, and I was involved in this international study of clinical densitometry in defining the clinical definitions based on all the available literature and the panel of experts who got together to come up with these guidelines. So you have to have one or more vertebral compression fractures to sort of make a diagnosis of osteoporosis, but this should have occurred without significant trauma. And the clinical diagnosis of osteoporosis requires presence of both a significant fracture history and size-adjusted low bone mineral density or bone mass. Now, what is significant fracture history? That is, if a child has had 2 or more long bone fractures by the age of 10 years, or 3 or more long bone fractures by the age of 19 years. And of course, you need to have good normative data for measuring bone density. So in Manchester, we devised our own reference data based on 800 children, but then what we decided to do in the United Kingdom was to amalgamate all the available reference databases, and we came up with this very robust DEXA reference data for over 3,500 children, both for the Hologic and the GE Luna machines, which are the 2 commonest DEXA machines. And it's important to do that because if you buy a DEXA machine, it comes with North American data, and DEXA, as I mentioned this morning, is affected by anthropometric measurements. So it's just like you can't use a growth chart from the United States in the Indian subcontinent or in the United Kingdom. You need to generate your own reference data, and Abid and I are hopefully going to start working on doing a study in Palestine here and generating reference data here. So what is Michael's bone mineral density? Well, as I mentioned this morning, when we're looking at the whole body bone density, we always remove the head because the head is relatively large in children, and it can sometimes mask the small change in the rest of the body. So the subcranial total body bone mineral density standard deviation score was 0.2, and his lumbar spine size-adjusted bone mineral density standard deviation was minus 0.1. So really, there was no obvious abnormality in his whole body, less head, or lumbar spine size-adjusted bone mineral density. So does Michael fulfill the definition for osteoporosis? Well, he hasn't had vertebral compression fractures. We haven't got this slide, but we did vertebral compression fracture assessment by DEXA, and there was nothing there. Has he got the diagnosis of osteoporosis, which requires both clinical significant fracture history and low bone mineral density? Well, he hasn't got low bone mineral density. So what about his fractures then? Why did he suffer so many fractures? Well, it turns out that fractures are not uncommon in children. So around 1/3 of boys and girls will sustain at least one fracture by the age of 17 years. This is the data from the United Kingdom General Practice Reference Research Database. And you can see that most of these fractures occur during the peripubertal period. So this is the time when Michael, between the age of 11 and sort of 13, had this sort of flurry of fractures. Why do these fractures occur during the peripubertal period? Well, this graph basically shows the age of the peak height velocity, and the bars actually show the increment in bone mass measured by longitudinal bone mass accretion measured by DEXA. And you can see that the peak height velocity occurs around about 8 months earlier compared with the peak, so this doesn't project very well, but the peak bone accretion sort of lags behind about 8 with peak height velocity. So around about the pubertal period, the bone envelope is getting better, but there is a lag in that envelope being filled with mineral. So you have almost physiological degree of skeletal fragility. And with high resolution PQCT, we've shown that you also sort of see a degree of sort of microarchitecture deterioration within things, but that is not deterioration, that is just again physiological. So basically, we were able to reassure Michael that his bone mineral density is normal, and he's just been unlucky enough to suffer a series of fractures around the peripubertal period. He didn't have vitamin D deficiency, but we would advise that he continue to take his supplements, and that he should not refrain from doing regular weight-bearing activities, because these are crucially important for providing trophic signals to the growing skeletons and to build good peak bone mass, which is important sort of protection against future risk of osteoporosis. But what about his tender Achilles? Well, we arranged sort of gait analysis on him, and indeed he had a very abnormal gait. We got our physiotherapist to teach him exercises to stretch his tender Achilles. We sent him to our orthotics people who provided him with insoles, and it improved his walking gait. Now it turns out that he was falling due to his things, so not only did he have peripubertal issues causing his transient fragility, but he had a real problem with his gait, which we were able to sort out using our physical therapists, occupational therapists, and orthotists. So this is not sort of abnormal bone disease. This is really part of the normal phenomena, but we were able to use sort of assessment and judicious use of bone densitometry to reassure and manage him. But of course there are many conditions which cause real skeletal fragility, and there's a long list here. In the interest of time, I'm not going to go through this, but we'll run through sort of a couple of cases of children with osteogenesis imperfecta. So let's start with case number 2, who's a girl called Maya. At the age of 2.5 years, she sustained 2 fractures following trivial injuries. At the age of 2 years, she fell onto carpeted floor and fractured her left radius and ulna. 6 months later, she fell on grass in park and fractured her right radius. Family history, no history of fragility fractures, joint dislocations, dental problems, or premature deafness that you would expect in osteogenesis imperfecta. When you examined her, well grown, but she had blue sclera. She had generalized hypermobility with Peyton score of 8 out of 9. She walked with a flat-footed gait. She had normal teeth. Many of these children have dentinogenesis imperfecta, where the enamel is yellow and crumbly, and the rest of the examination was unremarkable. So we made a clinical diagnosis of osteogenesis imperfecta based on a history of fragility fractures, blue sclera, hypermobility, and subsequently confirmed this by genetic testing. She had a known mutation in the COL1A1 gene, which causes osteogenesis imperfecta. And as you know, 90% of osteogenesis imperfecta are caused by mutations in one of the 2 sort of genes which code for type 1 collagen, COL1A1 or COL1A2. But the classification is somewhat interesting, because this was devised by David Salentz in 1980, and it was based on clinical features as well as radiology. So type 1 is classified as non-deforming, and most of these patients have blue or gray sclera. And then we go to type 2, which is lethal, and then we come to type 3, which is a progressive deforming form with multiple fractures leading to deformities of the spine and things. And type 4 is sort of intermediate between type 1 and type 3, and some of them have normal teeth and the other ones have dentinogenesis imperfecta. And all of them have hypermobility, rather fragile skin, propensity to hernias, sclera, and presenile deafness. And of course the whole genetics has expanded. Not only do we have COL1A1, but we have another gene IFTIM5, which causes osteogenesis imperfecta type 5. So these are all dominantly inherited. And then there are a whole host of genes which are associated with collagen processing, which cause recessive forms of osteogenesis imperfecta. And there is one gene which causes X-linked form. So in the United Kingdom, we have two panels for dominant form and for the recessive form. So you can do the whole lot if you suspect the concern. So these genetics are readily available. So this shows a child with blue sclera. This is a bad slide because it's on a blue background. If we're doing medical examinations for medical legal purposes, we have to do it in natural light and specify at what time it was done. If they come with a Manchester City blue top, then we have to change their top because sometimes it can reflect on their color of the eye. And these are some of the fractures that Maya suffered that I mentioned earlier. And this is a test for hypermobility, which is the Patent score, which is a 9-point score of hypermobility, and you can see some of the features of walking with a flat-footed gait, and this geniorecobatum, the knee sort of turning back, and this hyperextension of the forearms. And so Maya really was quite hypermobile with Patent score of 8 out of 9. And this shows dentinogenesis imperfecta. So the teeth on the right panel are sort of yellow, translucent, and crumbly. So not only bones break, but the enamel actually fractures. And in fact, the dental tooth can fracture, so that you can see the fracture through the dental tooth. And the dentinogenesis imperfecta may be mild. Sometimes it only affects the primary dentition and may not affect the secondary dentition. But in severe cases, it may affect really the secondary dentition as well. So what do we do for a patient like Maya? Well, there is in addition to hypermobility, there's an important component of myopathy, which all patients with osteogenesis imperfecta have due to upregulation of TGF-beta within the cells. So the doctors don't have a great role here. This is where you need your, we have highly specialized physiotherapists, occupational therapists who give advice about day-to-day handling, give them advice about posture, seating, gait analysis, deal with their hypermobility. These children struggle to write because their hands tire very easily, so they need appropriate pens, use of laptops in schools, 25% extra time to complete their exam papers, etc., orthotic input, and of course the therapists and nurses sort of liaise with the schools and local authorities to make sure that these children's special needs are not compromised. Medical treatment, well, I'll come on to that in a minute, but dental treatment is very important. We screen for presenile deafness, and of course orthopedic surgeons are very important friends. And many of these children get base of the skull problems, and so they may need help from neurosurgeons as well. So Maya's subcranial subtotal bone density was reduced, and so was her lumbar spine bone mineral density. At the age of 6 years, she fell in a swimming pool and landed on her bottom and complained of persistent backache. And you can see that she's got compression fractures of at least 3, possibly 4 vertebral bodies. At this stage, we basically optimized her vitamin D, ensured that she had things, and started her on compassionate grounds with intravenous bisphosphonates to prevent further vertebral fractures and to allow remodeling of vertebral fractures in a growing child, not after its growth has finished, but in a growing child, and bisphosphonates are very good at reshaping the vertebral fractures. So Maya sort of has had 1 or more vertebral compression fractures. She also has significantly low bone mineral density. She has got significant fracture history, so she has got osteogenesis imperfecta. She fulfills all the definitions of osteoporosis in children. And bisphosphonates, in pediatrics we don't use oral bisphosphonates because getting these children to take it on an empty stomach and then remain upright for half an hour and not eat for another an hour or so is very difficult to implement. And many of these children with osteogenesis imperfecta have very lax tissues, so gastroesophageal reflux is very common. And as you know, if you have reflux of already taking bisphosphonates, they can cause esophageal ulcers and things. So we tend to use intravenous permethrinate or zoledronic acid. We use more and more zoledronic acid, and basically osteogenesis imperfecta is a high turnover bone disease, and these bisphosphonates are taken by the osteoclast and cause premature apoptosis. So you're turning down bone resorption, allowing bone formation to make more bone, albeit of a poor quality, but that poor quality, having more of that poor quality bone translates into less fractures, less pain, and reshaping of vertebral bodies. And this shows very nicely that after 1 year of treatment, there is a significant improvement in vertebral heights, and this is the slide on the right, shows increment in alar bone density in a group of children from Francis Gloria's paper showing rapid increase in bone density. I'm going to finish off with the case of Aisha, who was a 2-year-old, who's a girl with sort of osteogenesis of type 8 caused by homozygous mutations in the LEPR1 gene, which is one of the genes which is responsible for aligning the pro-collagen molecules along each other so they can start folding to form the things. So she was born with fractures in utero. You can see these are radiographs taken at birth, so shortly after birth. And she had sustained fractures of forearm bones. There are multiple rib fractures, and most of the vertebral fractures are already gone. And there is significant flattening of the skull because of the soft bones. And so we tend to get a portacath in or a Hickman line, depending on their weight and their size. And we start them on bisphosphonates right from birth, usually with bemidronate, and then we switch them on to zoledronic acid. You can see that in May 2010, all the vertebrae in her spine had completely collapsed. And by 2015, with treatment, they had completely reshaped. You can see very, very impressive remodeling of the compressed vertebral fractures, which only occurs, as I mentioned previously, in patients treated with bisphosphonates when they're growing. You don't get the same effect after the onset of puberty. So growing child really significantly benefits from this treatment, and you can see normalization of the bone mineral density there. This is the effect of bisphosphonates. And of course she had limb deformities, but once you treat them with bisphosphonates, the bone quality improves, and this then gives our clever orthopedic surgeons to put these growing rods in. And you can see that the osteotomies have been carried out to straighten her limbs, and these growing rods have been put in so that as she grows, this will open and allow the allow the bones to grow quite normally. And so this goes on alongside a lot of input from physical therapists, occupational therapists, bone nurses, the whole bone team, and we do sort of fortnightly MDT, multidisciplinary clinic, for all our osteogenesis imperfecta patients, and with review by our surgeons and with our musculoskeletal radiology patients as well. So somebody like Aisha is never going to run in Olympics, but in the past they were confined to the wheelchair. And this video, I'm sorry, when you do it on the Mac and get to these things, it comes out, it's very difficult to straighten it. But hopefully it shows you that it, whereas previously they would be confined to the wheelchair, they, at least with a walker, get some degree of mobility, albeit with the use of a walker. So this really illustrates that the modern multidisciplinary team management of children with severe osteogenesis imperfecta has transformed the lives of these, the quality of lives of these patients. It has not normalized the disease. Stem cell therapy, we had a beautiful lecture earlier, has been tried at St. Jude's Hospital, and it did not work in this condition. So we don't have a cure at the moment. In the future, we may have other drugs. There are a number of different trials going on of drugs which may be used, and hopefully we'll have an anabolic agent in future to treat these conditions. So with that, I thank you for listening to me.